Hello everyone, good evening. I'm James Harding. I'm the editor and co-founder of Tortoise. And for those of you who are part of the Tortoise team, you'll know this already, but for those of you who are joining us as members or joining us for the first time, you'll appreciate that a think-in is essentially like an open editorial news meeting. And as part of our preparation for it, we pull together, or more generally, my colleague who's running the chat this evening, Ellen Halliday, pulls together those 5-slide guides, an attempt to try and essentially bring us into the conversation with a set of data that helps us understand it. And I mentioned this at the top because last night as I was going to bed, I thought to myself, I must call Ellen actually, because at our 11 o'clock meeting, she had presented those slides. And as I was going to bed last night, I was thinking, oh God, we've definitely got it wrong on the maternal mortality numbers. There's no way that it could be that you've got 8 per 100,000 white women dying of maternal mortality in the course of their pregnancy in the year that follows. And it can't be the case they're 34 per 100,000. And so just as I was going to bed, I checked the stats again and discovered, of course, that that was right, that the numbers that Ellen had found were right. And the reason I say that is because I think the strange experience as a journalist of this pandemic year has not been what a lot of people said, has not been this idea that there's a big change to our society. It's not been what's changed, it's been what's revealed. And it's even for people like me who spent our time in newsrooms day in, day out, thinking we're covering inequality, injustice, power gaps, that we suddenly find ourselves face to face, not with something that is terribly new, but something that is terribly old, something that's been around for a long while. And so that's why I hope that this conversation, this next hour, will, operate with the kind of informality, chaos, candor, directness of an editorial meeting, where we try and talk about something that, frankly, is right in front of us and we've walked past for too long, which is why are there such different health outcomes depending on ethnicity, depending on race. And we're incredibly lucky to have Mohammed and Pragya and Joe here with us. You'll have seen they're mentioned in the slides we started, but please do weigh in on the chat, and please do weigh in as we attempt to answer, in fact, really two simple questions. Why is this happening, and what can we do about it? And so I think I've got the questions, but I really don't have the answers. And I'm going to start, if I might, by coming to Mohammed and Pragya and Joe and seeing if you can help me with both. Mohammed, let me start with you, if you might. I imagine you have both a perspective on this that is systemic, if you like, looks at the country as a whole, but also personal, as you've been witness to it as a practicing doctor. Tell me, answer the first question, if you like. Why is it the case that we have such different outcomes in the UK depending on the colour of your skin?
Thank you, James. I think the answer to this question goes back to, as you in your introduction, that what is really surprising during this pandemic was that anyone was surprised at all, because we have known about the ethnic inequities in health, sometimes known as health disparities, ethnic health disparities, for a very long time. People have been looking at it for several decades. There have been several government inquiries, there have been several independent reviews, as recent as December 2020 by Sir Michael Marmot with collaboration with Health Foundation. And the reasons are very, very obvious. There are not many major game-changing known unknowns in ethnic disparities. First of all, we have to think about the social determinants of health. These are the conditions and circumstances people are born, live, grow, work, and age. And also what the powerful forces and the wider structural factors that shape these social determinants of health. And that includes systemic, sometimes known as structural racism, as a fundamental cause and driver of ethnic inequities in health, ethnic differences in socioeconomic status and adverse health outcomes. These are very much been proven by several decades of scientific research and also government inquiries and reviews. We know that it's not limited to the UK. From North America to Latin America and the Caribbean, indigenous people have worse health outcomes on almost all health parameters. We know in Australia, for example, that is the case in terms of health parameters, life expectancy, everything along those lines, and also countries like New Zealand and South Africa.
Mohammed, the point that you make, so I had some problem on the line, but Mohammed, can you just disentangle, because I suppose you've identified, these two key causes. People are always keen to get them, if you like, identify the difference between the social determinants and what you call the systemic or structural racism. Obviously, those are going to be quite entwined, those things, but I'm just wondering how you distinguish between health outcomes that are determined by socioeconomic circumstances and those that are additionally aggravated by issues of systemic or structural racism.
Absolutely. I think, as you said, they are intertwined. But the issue is that we know that ill health, health condition are caused by things like smoking, obesity, sedentary lifestyle, lack of exercise, poor diet. These are the direct causes of ill health. What are the causes of these conditions, the circumstances that provide the conditions that will make people sedentary, eat poor diet, and smoke, are these social determinants of health. And in effect, what causes these social determinants, or what shapes and influences these social determinants of health, are structural factors. So they are if we look at the way the causality of all, it's the causes, sometimes known as the causes of the causes of the causes. So these powerful structural factors, including systemic racism, shapes social determinants of health. Mm-hmm. And in the case of ethnic minorities, we know that ethnic differences are not accounted for by socioeconomic status alone. Mm-hmm. And racism in other forms, including structural racism, has its own independent effect, as it were. So that not only it shapes the socioeconomic status, but also it has its independent effects on the health of ethnic minorities.
Okay, well, I want to just see if we can come to a shared view. Maybe we won't come to a shared view on what those causes are. So I'm just going to come to Pragya and Joe too, and see whether or not you take a similar view or you see it differently. Pragya, what's your view on the answer to the why question?
Well, it is a really broad question, of course. And yes, there are historic legacies of oppression that have resulted in these kind of hierarchies, which are systemic and structural biases and the stereotypes that are formed. So I looked at lots of research studies which have shown that the diagnosis and treatment for people from different ethnic communities actually are different. As compared to people who are white. And you also mentioned, of course, the maternity of Black women, the maternal death in maternity, which is quite a stark statistic to look at. I think the causes are diverse. First of all, the causes are the kind of stereotypes that are held, which means that sometimes there's a lack of trust and faith in the healthcare professionals, that people from ethnic minority communities might not go to to healthcare professionals in the first instance. Secondly, there might be biases within the medical and healthcare professionals, which means that they might not address the concern of people from minority ethnic communities as quickly, as promptly. There are other stereotypes that are held, which a lot of research has been done in the US, primarily about how racialized notions of how pain is felt by different people is also affects how people are perceived. Sometimes I think there is also a notion that biology plays a role, and I am very wary of how biological determinants can actually be taken as a cause when actually systemic and structural biases are the primary causes for these disparities. And these biological determinism veers into dangerous territories of eugenics, which I'm very, very wary of when this happens.
And Pragya, can I just ask you, and this is a very blunt way of approaching the problem, which is obviously complicated and, you know, textured and has, I no doubt, lots of contradictions in it. But is there an argument for saying, look, you can hear what Mohammed has said. There are issues that here are social determinants. Let's call them overwhelmingly about, you know, socioeconomic circumstances that lead to, as he puts it, smoking and sedentary lifestyle and diet. And then there are issues of structural racism that, you know, we know are there. We can, you know, argue for a long time they're there. And then as you're saying, there are these behavioral issues among certain groups of patients, behavioral issues among certain people working within the healthcare sector. But is there a blunt way of answering this that says, look, overall, the largest single determinant of this is the first one, is the socioeconomic one. And if you tackle that one, that's going to be the biggest answer to the why.
I think the biggest thing is the systemic and structural racism that is embedded in our society. And I think all of these things are linked to that. I think the socio-economic indicators and determinants are linked to it. The behavioral determinants are also linked to it. And often we don't want to address the big issue, which is the systemic racism and the structural racism and inequalities that have been perpetuated through those historic legacies of oppression. And we want to ignore that, so we pay more attention to other things. Of course, they manifest in form of socioeconomic inequalities, or they manifest in form of behavioral disparities or differences in behavior. But the main root cause is the systemic and structural racism.
So for those of us who haven't spent our working life studying this, tell us, Pragya, in terms of, you know, I know you're a behavioral and data scientist. What do you see in the behavior? What do you see in the data that you can show people and say, look, here's the evidence of how structural racism works?
That's a really big question to think about the data that shows that. I think, first of all, we need to think about people's lived experiences, but also I think we need to think about history and how our society is racialized. Our society has hierarchies in it, racialized hierarchies in it. We know these stereotypes exist. We know these beliefs are perpetuated through people's behavior and these stereotypes that we carry. So it's very difficult for me to say, look, this is the data. And I think that is really a hugely complicated question to show the data that racism really exists, because we have to start from the belief that actually racism does exist. I mean, all the data is evidence of that fact. All the data that shows that actually Black women are dying more, or I wrote an article at the start of the pandemic where I said, actually, it is very likely that this pandemic is going to have an adverse effect on what we call as BME community, which is also homogenizing it, but minority ethnic people, because of the fact that they might not be treated, their concerns, their illnesses, they might not be treated as rapidly and as consciously by healthcare professionals. And I think there are multiple layers of intersectionality within it, of course, that we need to talk about. But it's very difficult to say, look, here's the data to show that racism exists.
Well, let me, if I can, come to Joe Bibby, because Joe, you've lived this, not just at the Health Foundation, but inside the NHS too. And I'm sure you must have had countless friends who in the course of the last year said to you, why is this? Why have you got such an extraordinary imbalance in outcomes? Why are so many more Black men and women dying than white men and women? And what is the answer, Joe?
So I think what we're finding in the analysis we're doing is that people from Black, Asian and minority ethnic communities have come into the pandemic with more disadvantage. So we talked about socioeconomic determinants of health. And just to try and illustrate this, and why this does affect particularly people from ethnic minority communities. If everyone in this society there was a sort of normal distribute, or an even distribution of white people, black people, Asian people across that socioeconomic spectrum, then you'd expect 10% of white people to be in the lowest 10% of economic groups. You'd expect 10% of black people, 10% of Asian people, and so on. But when you actually look at the distribution, what we find is that 16% of Asians are in the lowest 10% of socioeconomic groups in this society, 15% of black people, 13% of other minority ethnic groups, and then 9% of white people fall into the lowest 10%. So given everything we know about the way in which your social and economic circumstances affect your ability to lead a healthy life, the fact that we have a population which has certain parts of that population disproportionately in lower socioeconomic groups builds in that disadvantage and creates barriers to people's ability to be healthy in the first place. So we've...
Joe, I only interrupt you just because I want to pursue this point, and I appreciate Pragya's point, but I think there is a real debate now about whether or not the finger of blame, if you like, is pointed at the healthcare system or the economic system. And I suppose one of the ways of getting clearer view on that, not a firm answer, but a clearer view on that, would be to say, is there any data that shows what the comparative outcomes are for that 9% of white people and those 16%, I think you said, that were British Asian people, i.e., are outcomes, regardless of race or ethnic identity, for the poorest 10% of the population broadly the same?
Yeah, so I think what we're seeing in the data we're looking at is that there are poorer outcomes for people based on their socioeconomic circumstances. And as Mohammed said, over and above that, there are poorer outcomes for people from minority ethnic groups. And I mean, there's not going to be simple answers for this, but some of the hypotheses are that perhaps people from certain communities seek, services at a later stage, maybe because of lack of trust, maybe because of poor experiences previously when they've tried to access services. So there's something about whether certain groups didn't access services, healthcare services, at an earlier stage in the progression of the disease, so that by the time they access it, they're more seriously ill and they're more at risk of a poorer outcome. So that's kind of one side of it. The other side is, as Pragya was saying, was just about whether or not people have different experiences and quality of care because of presumptions and assumptions that are made by the caregivers. So I think what we'd say is, first of all, we absolutely know that people from Black and Asian and minority ethnic communities came into this pandemic with poor socioeconomic circumstances, with poorer health, underlying health is poorer. So that put them more at risk of more severe outcomes. And then the way in which they were able to access services potentially did create some barriers or, poorer care that may then also go on to compromise their outcomes. But this is, one of these things where it would be very hard, I think, certainly at this point in time, to be able to disentangle what's the different contribution of these different components.
And arguably, it's a slightly pointless exercise in that once you've acknowledged that they're all there, you have to think about how you tackle all of them. I'm only pressing the point in the light, obviously, of the recent government review in this area, which, if you like, tries to emphasize one element over another, and wanted to see that in the context of health. I'm going to, just before I want to come, if I might, and I don't know whether David Rapp is there because he's raised a point, so I want to come to in a moment, but I'm just going to bring in my colleague Ellen Halliday, just because I think it's quite useful for people to see how we try and identify the stats that matter in this, And obviously, it's a inevitably an inadequate exercise. They're snapshots and they're highly partial. You know, they're only a bit of the picture. But Ellen, do you want to just, if we can, bring up that set of slides? And I just wanted to do a quick spin through them. Here we are. Just talk through, can you just talk through and explain, you don't need to explain the slides because people can see them, but explain the choices that you made in identifying these particular ones.
Yeah, sure. And I mean, as you've already said, these slides can only provide a snapshot. And I think this is almost one of the most kind of complicated topics I've tried to try and make these slides on. So it really is just a glimpse at some data. I wanted to look inside the NHS because I think part of the problem potentially with the bias is about, you know, who is listened to, who makes decisions. And so in that regard, who are in senior positions inside the NHS must surely have an impact on the health outcomes of the people there who are then being treated there. So, I mean, 78% of NHS staff, there are 1.3 million, are white, which is actually slightly lower than the percentage in the UK population as a whole. But they tend to hold more senior positions, both in medical and non-medical roles, whereas people from non-white backgrounds tend to hold more junior positions. So this chart is about non-medical roles, but I think it still tells us something about the decisions that are made in terms of healthcare provision and resources, which, you know, I'm sure has an impact on the health outcomes of the people being treated there. If we could go to the next slide. Again, you know, we know that COVID has disproportionately impacted certain groups, and white people have been most likely to survive COVID, whereas Black men and women have been most likely to die as a result. It's worth mentioning, by the way, through these slides that some of the data came from the NHS in the first slide, the rest from the ONS. So you see ethnicity described in different ways. But a lot of it is based on census data. So when somebody actually dies of COVID, their ethnicity is not recorded on the death certificate, but rather the analysis is linked to the 2011 census. So that's how the ONS kind of came up with this data here. Go to the next slide, please. We've also mentioned socioeconomic factors, and I did want to bring that into the slide as well. Healthcare, we know, can't be considered in a bubble, but is linked to, you know, to all aspects of life. And undoubtedly, the high proportion of Black workers who are key workers during this pandemic meant they're exposed more to the virus, to potentially to higher volumes, viral loads, and therefore were more vulnerable. And then within families, Bangladeshi people are much more likely to live in overcrowded housing than white people, which could increase the spread between family members, and, you know, therefore also to older family members who are more likely to pass away. And then the next slide, please. We can't talk about COVID and about race without talking about vaccine hesitancy. This is from January and February. So overall, 9% of UK adults were hesitant towards the vaccine. But you can see for Black populations there, it's over 40%. And so I think there's a discussion to be had both about where that comes from, potential lack of trust, potentially based on previous experiences, but also the opportunity there to improve communication, to build trust, and to kind of maybe limit the health inequality going forwards if that gap can be closed. And then the last slide, please, Connor. This point, of course, that James already mentioned at the outset, and I think I already put the report in the chat, but I'll do it again in a minute. So the statistic there, 34 per 100,000 Black women giving birth who actually die within, I think the report actually says for this figure, it's within 6 weeks after giving birth, although the report also talks about women who died within a year. The biggest cause of death is related to mental health, which, you know, is also, we're not just talking about physical health inequalities and biases, but also mental ones there. And yeah, the report mentioned a constellation of biases that can have an impact on maternal fatality rates.
Ellen, thank you. It's so interesting, and as you say, I don't think any of us are claiming that that's a comprehensive view, but it's quite an interesting starting point for thinking on lots of fronts. And the thing that was interesting is, as you were speaking, I was jotting down a note from the things that Joe and Mohammed and Pragya had said, and I just written down a note about the extent to which patient behaviours, I've written down question mark, influenced and instigated by systemic racism in healthcare, when Samin wrote this interesting thing in the chat about there is well-documented comparative research on lack of trust by people of Black ethnicity in clinical professionals. I don't know whether, Samin, we can get you. I think you messaged me to say your mic and your camera, which is quite a combination if we do want to hear from you. Your mic and your camera are not working. Is that right? Can we hear from you at all? No, they're still the same. Okay, no problem. Sumi, listen, I'm gonna ask Pragya, if you might, though, to just answer that, if you would, because there is something really interesting there, and I'd love to understand it more closely. The relationship between people's disinclination, let's say, to go and get a jab, or disinclination to go even for a checkup, and the extent to which that happens within communities, and the extent to which that's, if you like, aided and abetted by the behavior of the healthcare system.
Yeah, I think first of all, I just want to comment on something that came up through what Joe and Mohammed were saying, and you were talking about the relationship between the socioeconomic and the systemic and structural. And I think we need to really be very aware of the intersectionality of these effects. And sometimes we forget the intersectional aspects of it, that actually these two are very much interlinked, and people's identity as belonging to a lower socioeconomic strata or class intersect with race or gender, and that heightens the bias against them. So these multiple identities and how that affects bias is also very, very important to talk about. In terms of vaccine hesitancy and the research that shows that, yes, there is a reluctance to trust healthcare professionals or medical diagnosis and treatment, I can speak from research, but I also wrote a piece about vaccine hesitancy to address some of the data around it. And yes, I was just very concerned that yes, there seems to be some hesitancy within these communities. First of all, and there are a number of causes that I outlined. First of all, of course, there is the historic kind of lack of faith and trust that we need to address. The lack of transparent information is really important about how these communities are, why it is there. So we need to think about the social and behavioral reasons why this is there. But also, I think sometimes it's used to weaponize this against some of the communities, saying, oh, actually the Black people are not taking up vaccines, so that is why they're dying more in the COVID or due to the pandemic. But actually a document which I unearthed, buried deep down, showed that there was an equal amount of hesitancy amongst other white ethnicities, which are non-British as well. So it is perhaps something to do with how the information is being disseminated, and what are we doing with that information, even if the data is correct. Are we just cherry picking some of the data to ignore or dismiss the racism or the effects of racism in our society?
And Peggy, can I just ask you one thing? I really appreciate that point, because I hadn't heard that before, this point that says actually there's distrust of power by people who are excluded regardless of color. What I am interested in, I also haven't seen anywhere, is any measurement of this over time, whether or not, and I'm not sure what sort of comparable data there is, but whether or not trust is falling or rising, whether or not, if you'd had in effect a similar circumstance 10, 20 years ago, you think you would have seen different levels of trust.
Yeah, I think you're right in terms of the temporal values. I don't think there is any data, really concrete data, even now, in terms of measuring this faith and trust. The whole report about how NHS is very top loaded with white professionals at the top, and so that means that a lot of policy making and decision making is still not in the hands of the minority ethnic communities, which can cause imbalance within an organization, is something that only I think fairly recently that came out in a report or a survey or a study that was done. So I don't think we have any data from 10, 20 years ago. As far as I'm aware, I've looked at quite a lot while I was writing the book, but since then as well. But even now, I don't think we are measuring that. I don't think we are doing adequate survey. And even if we are doing that, I'm very much averse to this notion of using BME as a category, because it does not disaggregate the data according to different kind of communities within that homogenized group as well. So I think we need to do that as well.
That's really helpful. And you know, just for what it's worth, you know, people get frustrated by the clumsiness of journalism in this area. But Ellen is unusual in just flagging up the fact that we get confused by the different ways in which different organizations measure different groups, and there is a degree of muddle around that. I want to take, if we can, a sense that we've addressed some of the, to use Mohammed's great phrase, the causes of the causes of the causes, but try and think about what the answers might be and what the future might look like. And I'm embarrassed to say that, you know, when George Floyd was killed and there were big arguments around racism in the criminal justice system, you know, people like me could point to David Lammy's review and sort of go back and identify certain things, but as regards criminal justice in particular. But Mohammed, I wanted to start with you. I don't know exactly where to look and find, okay, well, here's your off-the-shelf set of answers to how you begin to deal with some of these, you know, cruelly different outcomes in terms of ethnic identity and health. Is there, in your mind, a good set of proposals that just have been sitting on a shelf but never been enacted?
Yes, absolutely. So there are several things that could be done, and we know that some of them are evidence-based that will work. The first thing is to acknowledge the factors that cause ethnic disparities. A first step would be to acknowledge that there is disparity and there is a problem and it needs to be addressed, and try to find the root causes of those and acknowledge the factors. As you mentioned earlier, recent government reports, judging by that response, we have gone back a few decades in terms of acknowledging the causes of disparities and acknowledging the extent of disparities. So these two are important first steps. You also mentioned the Lamy report.
Mohammed, can I just stop you 1 second before we just sort of, because there's a risk we tiptoe around this, and we should probably, if we're going to have this conversation, address it. Can I just challenge you on that, in the sense that, yes, you could say that this Tony Fuell's report, the Commission on Racial and Ethnic Disparities, is an example of having sort of stepped back. But you could also say, actually, what's interesting is that there was an attempt to make an argument to land a particular case here. And actually, the body of public opinion and certainly the media reception of the headlines that were pre-briefed on that report showed that actually, if you like, the center of gravity on public debate around this had really moved. And there was an unwillingness to accept or to, if you like, dismiss these disparities and to somehow buy into that particular worldview. Do you take any comfort from that, or do you think that's just, you know, putting a gloss on it?
No, I take huge comfort from that, because as you said, there's this center of gravity has shifted because of the evidence. The weight of evidence is heavily on the side of people who have said for decades in the government, in previous government inquiries, independent reviews, scientific research, they've all said the same thing. So the fact that organizations acknowledge it is a huge progress and as something irreversible. But in terms of the reason I'm mentioning the role of a government and a state is that we have had about 6 government inquiries into ethnic disparities, not just in health, but also on education, criminal justice system, and employment. Baroness McGregor-Smith's review on ethnic disparities in employment, hugely important reports and reviews, and they have made many very, very valuable recommendations that have either not been implemented at all or fallen by the wayside. And those are the first steps in terms of mitigating the effects and trying to reduce the the disparities that we are witnessing with COVID and beyond is to implement those recommendations, and also to implement the recommendations of independent reviews. The most important one is the Marmot review from 2020 in February, and also his most recent one, Build Back Fairer, in December 2020, which specifically mentions the dealing with reversing and reducing the socioeconomic impact which disproportionately affected ethnic minority groups in terms of addressing poor housing and other factors. But something I mentioned, someone mentioned earlier, I think it was Pragya, is that we can't deal with health in isolation. Ethnic disparities in health is not something that can be dealt on its own. If we are addressing ethnic disparities, we must address inequalities in education, employment, and criminal justice system, because in isolation, healthcare will not be able to deal with the extent of disparities we are seeing across the board. In terms of the evidence base, we know that in the United States during the 1960s and 70s, targeted civil rights policies narrowed economic gap between whites and blacks. It reduced income inequality and improved the living conditions of Black communities. So we know that the most effective way to deal with ethnic disparities is the leadership, commitment, and investment by the state. So the role of government is absolutely crucial, because that's where the most of evidence comes from with dealing systemic racism, in particular with residential segregation.
Mohammed, thank you. I think, Joe, can I ask you, I'm sure you'll agree with that point that Mohammed's making, that you can't deal with healthcare policy in isolation, or at least there's no point in doing that. Nonetheless, I'm going to ask you to focus on it, to address what you would do in terms of the operations of the NHS and broader healthcare policy, assuming that the rest of the government had, was beginning to, pay attention to the issues that Mohammed's mentioned around education, criminal justice, economy and employment. What would you do in the NHS and on healthcare policy in particular?
Okay, so I think, one of the things about the NHS is that it does respond very well to data. So there is something, I think, about the more data we have that highlights the sort of day-to-day inequalities that exist in access to care, use of care, outcomes from care. I genuinely think that, you put that in front of clinicians, you put that in front of hospital managers, GPs, they pay attention to that, and they'll start asking the questions, and they'll start thinking about the solutions. And, we've seen that in healthcare, in the way it's tackled patient safety, in the way it's tackled waiting times, it responds to data. So I think there is something about, in this case, actually more data certainly can help. I think the other side of it is looking at, how easy do we make it for people to access health services? And I think, one of the things that's really struck me in the last few months with the vaccine program is the way we've seen some really innovative thinking about how we take the vaccination program out to communities that people would kind of give that label of hard to reach. But what we know is it's not that they're hard to reach, it's just that we're putting up barriers, or there are barriers in the way to them accessing services. So there's something I think we need to really learn from this experience and start thinking, well, if we can do this in an emergency for a vaccination program, how do we really start to think differently about the way services are provided and deployed in communities, and the way in which people are invited to access them and provided the information of what's there? So I think there's practical things that will happen.
And Joe, can I just ask you two questions about the data point? Because I think people like me would take a certain amount of comfort from the thought that healthcare practitioners can look at data and change their behavior accordingly. I think I'm right that you worked in the NHS in Yorkshire. Is that right?
Yeah.
I guess I've got two questions. One is there much ability of the NHS to look at comparable outcomes from different hospitals, different areas, and say, why is it this particular area or this particular hospital is doing better than others? And is it possible to look at different treatments and different illnesses and compare those outcomes, i.e. that both within treatment and within different areas, there's a level of, if you like, virtuous circle competition.
Yeah, I mean, there is certainly. I think, it comes down to the quality of data that's collected. But if you take, as I talked about earlier, theme of patient safety, which I did a lot of work on sort of 10 years ago, there was big variation in terms of whether you'd get an infection when you went into hospital, whether you might have a medication error when you went into hospital. There was a big push to look at comparative data, and so that people could look at their own performance and they could compare it and they could learn from it. Now, one of the challenges we have on sort of inequalities, in particular when we're looking at race and ethnic inequalities, is whether we've got the right data to enable people to see that and act on it. But I think I'm certainly seeing some places across the country really starting to tackle this. And I do feel a bit like, I think Mohammed said, sort of feel a bit hopeful about the sort of shift that we've seen. I was a non-executive on a trust board just over 5 years ago. I've really been thinking, could I remember a conversation about health inequalities? And in all honesty, I would struggle to recall that. I've just joined, I'm starting in June as a non-executive as a different hospital. I've been to a few meetings shadowing. Every meeting, health inequalities is coming up. I mean, there's just been a massive shift in the awareness and the concern behind this. And so I think, I think there's cause to be optimistic about what institutions like the NHS can do, but they don't work in isolation. They sit in a wider society where we know there are wider structural barriers to people in terms of being able to access good jobs, good housing, and so on.
Joe, that's massively interesting. Is it the case that the discussion coming up, in the shadowing, is coming up because there's been some mandate from on high, or do you think it's one of those things that happens instinctively, reactively in organizations when they see the data that we're all seeing and think, good grief, we've got to do something about that?
Yeah, I think my sense is, because there has been some guidance come out, but just only in the last month, I think, that's highlighted this as a priority for coming year. But I think these conversations are, as you say, everybody's seen the stories that have been sort of explained in the media over the last year. People have, some people have experienced it more directly than others. It's something that's become illuminated in a way that it wasn't even, sort of 18 months ago.
Yeah.
So I think there's something everybody's feeling. This is something we need to be talking about.
Pragya, I want to come back to you in one moment. Before I do, though, I want to bring in two people, because they're two different aspects of the issue that you talked about, the trust issue. One is my colleague, Tommy Babs. Tommy, are you there? You were just talking about the reasons for, or the conversations around, lack of trust. I just wonder whether you'd just sort of give some examples of how you see that, how you've witnessed it, and also a bit amongst whom. I'm interested amongst age, because I don't know, Tommy, whether you joined Tortoise at this stage, but we had these conversations in the summer of last year, and it was quite interesting within families how much it divided generation.
Yeah, so I think the lack of trust thing, I just know, as far as myself, a lot of my information is kind of anecdotal, but there's an increased understanding, knowledge of historic treatment of Black people. I can only really speak for Black people as well, but historic treatment of Black people by researchers, for medical research, and even for vaccine testing. As far as age goes, my parents have both taken the vaccine. And I've always gotten my other vaccines. When HPV vaccine came out, I got the vaccine. But within the community the Black community that I know, there were a lot of, a lot of it was ridiculous kind of conspiracy theories. But a lot of people took those very seriously. And that, coupled with learning about this history of the treatment of Black people by the medical field, kind of made people think, at the very least, I'm going to wait till other people get it first.
And is it particularly around vaccines, i.e. the conspiracy theories, because, vaccines have a history, don't they? Is it specifically around vaccines, or do you think it's, to Pragya's point earlier, about just a broader distrust of, medical practitioners and hospitals and doctors more broadly?
I think it could be a broader thing. For me, I know myself and some of my other friends said when they were younger, some of their parents actually told them, you need to tell the doctor that you feel a bit more sick than maybe you do, purely because they may not believe you in the first instance. Yeah. So obviously that's not necessarily about vaccines, that's just medical treatment in general. So I think there was an understanding that, we're not being believed, we're not being seen in the same way as perhaps the white woman that comes into the doctor's office.
Okay, Tommy, thank you. I mean, it's amazing. I see you. I don't know whether you can see as you were speaking there, Tommy. Pragya nodding away at exactly that. Pragya, do you want to just pick up on that before I go to Yelena in a moment? Because I suppose there are two things there, and if I'm totally honest, I'm not exactly clear what's going on still. I don't quite understand what I understand what, if you like, the kind of inbuilt fear and hesitancy around A, going in for a vaccine is, and B, the way in which doctors have historically treated Black people and the perception. I'm trying to work out specifically what you understand is going on around COVID-19.
I mean, it's all interlinked, isn't it, James? Because obviously the whole history, if we look at history, yes, was what Tommy is saying about the medicalization of Black bodies it is something that people are becoming more aware of, and there is an inherent fear in the communities about how people of color or bodies which are not white are treated in the medical and healthcare professionals, or how they have been in the past. So that kind of perpetuates within communities. And of course, what she's talking about, conspiracy theories, there's an element of social media and fake news and echo chambers and all those kind of things feed into it as well. When there is no clear information or transparent information coming from the government, of course, this government hasn't inspired a lot of confidence in so many of us. And the recent report is one example of it. When you dismiss structural racism, how do you feel secure in a place like that? But also, vaccine, there has been a hesitancy because it is linked to that kind of notion of faith and trust in what's being put out there and who are being used for experimental purposes. And are we being told all the information and the consequences of taking up this vaccine? Should we wait and see what other people have faced? We know that vaccines in the past or recent past, especially with pregnant women, for instance, they took the medication, which resulted in birth of disabled children or infants. And that was linked to that. And I just want to pick up very, very quickly, and know, conscious of the time, about what Jo said about data. And I think that's really what she makes a very strong point about the need to collect more data and more evidence. But I do also think that we need to take lived experiences into account as well. So how can we just rely on data? Because data often can be used to confirm our existing beliefs. And we know that we all carry confirmation bias, that we use information to confirm our existing beliefs, and we interpret information to confirm our existing beliefs rather than find information or look for information that's going to disconfirm it. So I think we need to show trust in people more before they can trust the government, the policymakers, the healthcare professionals as well, I think.
Can we just, Pragya, I'm going to come back to you, because unfortunately, actually, there's a question I think is I'm hoping that you might be able to help us understand. Yelena Sofronevich, if you're there, just to let everyone know, Yelena put an interesting point in the chat, which was about ethnicity and mental health detentions. I messaged her saying, can you talk to me about this? And she said, I'm no expert, frankly, nor am I. Happily, we've got someone in the room. But Yelena, what was the point that you were seeking to flag up?
Yeah, so I remember reading about this in January, about the Mental Health Act, and around the reforms that they're proposing, because basically under the Act as it currently stands, Black people have been 4 times more likely to be detained and 10 times more likely to be subject to community treatment orders. And it just reminded me of the same sort of violence and impunity towards ethnic minorities that we see in the discussions about policing and security. And I really worry that it could feed into like a biological view both of race and of mental health. And I think Dr. Pragi has been really right to flag up the need for an intersectional look at this. So we know that Black and minority ethnic communities have suffered much worse in terms of their mental health during COVID. But I think that that's due to the disproportionate socioeconomic impact we've seen at the same time. So I just, whilst you were chatting, James, I just had a look up with Mind, and they had a really interesting study out in July of last year that said that almost 1 in 3 Black and minority ethnic people said that problems with housing made their mental health much worse during the pandemic compared to 25% of white people. And there are loads of other stats in that study as well. I'll put a link in the chat because I think it's really interesting there when you look at it to see how you know, this disproportionate impact on socioeconomic condition will ultimately affect people's mental health. And I think that's something, it's a discussion that goes beyond race as well, and it's something that applies to our discussions of mental health more broadly.
Yeah, Yelena, you remind me that Hashim Mohammed, I don't know whether you were here with the thinking that he did for us a few weeks ago, has become a contributor, and he said, you know, every problem in Britain is rooted in housing. And I was thinking, really, every problem is like, could we just take Yelena's point though for a second, and if you like, just drill into it here. It feels as though there is a real argument that, if you like, this past year has really brought us or forced us to think more seriously about mental health in the UK and about ethnic disparities. And what Yelena's put her finger on is the intersection of those two things, right? And I wonder whether or not you share her view that there is something, if you like, even more alarmingly worrying here, which is that the stats then create a perception around race and mental health that itself becomes, if you like, either self-confirming or fulfilling or, you know, perpetuating.
Yeah, I mean, yeah, thanks for bringing that up, Elena, because I think that's really interesting about mental health. And I was looking at that as well. And I agree that there's a danger that it can again go into this whole biological notion of whether race, that there is a biological difference between race. We know race is a social construct. We know race has no biological or genetic basis, but that can be the case. But then there are stereotypes linked to it as well, as you mentioned, about Black men are considered more aggressive, more criminal, they're incarcerated more, they're detained more. And so that just becomes linked to that, how those stereotypes are perpetuated. There's also those notions of within communities, how the stigma attached to mental health and mental well-being as well in certain communities where we don't talk very openly about mental health, and until it becomes quite an exaggerated problem as well. And also these tropes of Black women have to be strong, these kind of strong Black women, which I recently read some number of articles, very interesting ones. And something I also looked at is about how that perpetuates this need to actually not show weakness and vulnerability. So women might, or even Black men might not go until it becomes quite late to seek help.
Mm-hmm.
And I know from personal experience, seeking help for mental health in this country or within the system is not easy at all.
Mm-hmm.
And I think it's also, yes, linked as a minority ethnic person to be showing vulnerability and weakness is a hugely problematic, which I know from personal experience as well. So there are lots of issues in this, which I think we really need to carefully look at.
Pragya, thank you. I appreciate the time. And of course, we've taken on one of the most difficult and arguably important subjects, and then still said we're only allowed to give ourselves an hour. So we're constrained by time. But I just wanted to come back to Mohammed and Joe for a final thought. Mohammed, you've been clear about what can be done, right? On that, the implementation of things like Marmot, what would you most like to see the government do next?
Address, reverse and mitigate the socioeconomic status effect, because that has affected, the decade of austerity has disproportionately affected ethnic minorities. And we know that it can be done. We can reverse the socioeconomic status and narrow the disparities gap, because most of the things. It's absolutely right that most of these disparities stem from from poverty, from poor housing, from overcrowded multi-generational households, and all these things. So I think that is the crucial part, and it cannot be emphasized enough. And that is linked to broader structural factors that, unless we address those, we will not get to make those changes. But the other thing that the NHS, you asked Joe just quickly to mention, that the NHS can do is to increase the representation of ethnic minorities in senior positions, because there is a lot of evidence that improves the outcome for patients significantly, not in terms of implementation of policies, but also racial concordance and other things. So not just senior positions, but healthcare professions in general, that is an important thing. And the other thing is around data. NHS Health and Race Observatory recently established is a major step forward, because in the UK, we are far behind the United States, New Zealand, Australia in terms of collecting data on ethnicity and health outcomes. So I think that is really important. And as Elaine mentioned, we were not even collecting ethnicity at death registration, which is a major flaw, and we can't even properly estimate the life expectancy differences, so we have to rely on secondary measures of estimating these crucial health data. So I think that is really important to implement these strategies within the NHS and wider with regards to socioeconomic factors.
Well, now, thank you. Joe, thank you. I'm aware of time, and Pragya, thank you too. I want to say that this is one of those subjects where I think we're making a start. I do come away actually, fun enough, from this thinking, and if you haven't been to one before, the aim is to try and come away, as Ellen says, informing what our newsroom does next. Actually, it's incredibly helpful in trying to answer those two questions, but I think we've done better than that. In the why, actually, you do come away thinking, all right, look, there's clarity, there's a link between these four things. You know, the social determinants, the socioeconomic issues, the issues that we've seen in terms of health preconditions that, as Joe says, come from those socioeconomic conditions. Then they're the behavioral issues of different groups, which themselves are either influenced, instigated, or a reflection of systemic structural racism within the healthcare sector too. And so I think you can see those four things intertwining and linking, and it's incredibly helpful. What's really useful is then beginning to think, all right, well, how would you begin to think about addressing it? I take Pauline's point in the chat that one of the few good things about the past year is we're looking with more energy at how we address it. And I take your point, Joe, about how you've actually found health inequalities, these disparities being talked about in the NHS. I do think that Mohammed's absolutely right that the issues in the Marmot Review are the central ones. In many ways, they are the central ones of our entire society, and this is one element of them. I take the point that you were making, Joe, about data, and Pragya, the fact that you're able to identify these issues and data points actually makes a huge difference and could potentially change behaviours. And I suppose the real question is going to be, as we emerge from lockdown, whether or not the innovations you talk about, Joe, continue, whether that spirit that we've seen around vaccines continues in the health service and that appetite continues in government. I'd make one final point, which is that sometimes you sort of start off having a conversation about one thing and you're prompted to have a conversation that takes you further. I really think that, you know, listening to Tommy and understanding suspicion about power and power in the health sector, it is perhaps the sort of line that runs through all of this. And when Yelena made the point, she took me to a place which I always find shocking and a bit embarrassing as a journalist as old as I am, when you see a scandal in plain sight, and this intersection of race and mental health and detentions and the community orders that Yelena mentioned makes me think that perhaps that's a place that we should actually take our journalism in reporting terms. Because if you did, you could possibly get to one of those issues that would not encompass all the others, but would typify it. So we'll go away and have a think about how you do that, whether there's a story that can do that and serve as a way of thinking about these issues more broadly. But as a first step in the conversation, I expect we're going to have many more times. I just wanted to say a heartfelt thank you to Mohammed Razai, to Dr. Pragya Agarwal, actually Dr. Mohammed Razai too. Sorry, you lost your doctorate, your qualifications right there, Mohammed, and to Joe Bibby as well, and to everyone else who's joined us this evening. Thank you for making the time. We can't thank you, and we can't mill around and chat and compare notes. But my colleague Helen's right. This really does drive our journalism. So if you have anything else that you want to add in the chat, please do weigh in. As ever, a really interesting evening. Thank you very much for making the time to be with us.